Hi, welcome back to chapter 13. We're going to continue on the lower urinary system today and go ahead and try and wrap this up. So thank you for getting started with the anatomy and some of the physiology of the system last week. We're going to move on to more of our abnormalities and pathologies this week. One area I want to spend a little bit of time on before we get into the pathology is going to be the 3D and 4D scanning techniques. We briefly talked last week about how we can use 3D volumes to really create what we would call a virtual cystoscopy, where we can see the idea of the inner lining of that bladder without having to introduce a scope. We utilize 3 and 4D sonography to do this. So with 3 and 4D, most of you passed your SPI exam, so you know that it's the accumulation of multiple layers of data where it will then utilize those layers to create a volume. 3D volume measurements can then be obtained using a virtual organ computer-aided analysis, which can be referred to as VOCAL, and it will then ultimately create a 3D model of the organ. Another approach to getting really good visualization within the bladder would be an endoluminal sonographic transducer. So on this, it would be something very, very small, like a urinary catheter attached to a transducer. That transducer would be really manipulated from some controls external to the patient, and it would be advanced up the urethra, and it would be utilizing sonography from inside the bladder to assess the bladder walls. These can be very useful to get that high frequency, high detail information, but this is going to be a specialty exam that you're not probably going to be utilizing unless you're working in a specialty urinary clinic or a urologist's office or surgically. So now into the abnormalities of the lower urinary tract. So we're really going to be focusing mostly on our ureters, bladder, and urethra. So there's a condition called bladder duplication, where there's going to be 3 different types that this can fall into. This is going to be kind of similar to what you remember from, your didelphic uterus or your bicornuate uterus, things like that. So the first type is a peritoneal fold. This can be incomplete or complete, where it kind of invaginates. There's a septation that kind of compresses or separates that bladder into two separate components. We can have something called a true septum. This is going to be something that actually grows down from the fundus of the bladder and separates the bladder, either sagittally or coronally. And then there's something called a muscle band that divides the bladder into 2 unequal cavities, and this is usually in the transverse plane. Now, the complete duplication of the urinary bladder is rare. Anytime there is a duplication, it's going to kind of act as a settling point for urine. And so we have to be aware that anything that occurs because of stasis is going to be at higher risk of occurring with a duplicated bladder because of that lack of efficient emptying. Now, urethral duplication, this is typically associated with a duplicated collecting system. Sometimes this urethral duplication occurs just, within a couple centimeters of the kidney, and then the ureters join, and then we have a singular ureter from there on out. But urethral duplication can actually occur all the way down from kidney with a duplicated collecting system, all the way down to actually create an additional insert into the bladder. This is caused by embryonic urethral branches that they branch prematurely, and that leads to a partial division and separation. The timing during embryology of that branching occurrence is going to determine how much of the ureter is duplicated. This can occur unilaterally, so just on one side, or it can affect both sides of the urinary system. So an incomplete duplication would be where the bifurcation of the ureter is near the renal pelvis, but it can joins with the ureter, and only one ureter on that particular side would empty into the bladder. If it's fully a complete duplication, we would have 2 separate renal collecting systems, 2 separate ureters, all the way superiorly to inferiorly, and we would have 2 separate inserts or UVJs on a particular side of the bladder. So Now, what they typically see is that a ureter from the lower renal pelvis will actually migrate and enter the bladder into the normal urethral orifice there at the left or right trigone, depending on the side it's at. And then the ureter from the upper pole usually inserts into the bladder inferior to the ureter of the lower pole. So kind of interesting. It's a little counterintuitive of how that happens. In females, the more inferior ureter can actually miss the bladder altogether and drain ectopically into the peritoneum, the uterus, the vagina, or the urethra. Whereas in males, if it misses the bladder, it can insert right into the urethra or even into a seminal vesicle. It's more common to have a duplicated urethral system in females than males, and it's also associated with duplicated urethra, bladder, and genitalia because of the close relationship as they develop. Bladder agenesis, this is just remember that A means no, genesis would be development. So bladder agenesis means there's no bladder developed. Most infants born with bladder agenesis are not compatible with life and will be stillborn. So in utero, we usually take over, the fetus will usually start really taking over amniotic fluid production via the bladder near around 16 weeks. And so if they do not have a bladder, they cannot urinate and they cannot maintain good amniotic fluid levels. Well, when there's not good amniotic fluid levels, what happens is the baby becomes trapped and smushed inside that uterus. The other thing that happens is that they are unable to breathe fluid in and out to help develop their lungs. So with bladder agenesis, typically these fetuses will be born and have very hypoplastic lungs and ultimately die of pulmonary hypoplasia. So we should always be looking for a bladder on our obstetric exams to ensure that the fetus does not have bladder agenesis. A secondary indicator would be later in that second or third trimester pregnancy. If we're seeing really low fluid, we have to be concerned that it could be due to bladder agenesis. Renal agenesis would be always lethal, really for a lot of the same reasons that bladder agenesis is, except with an additional issue. As long as you have kidneys, you're at least able to function filtering your blood. With renal agenesis, not only does that fetus not get amniotic fluid to develop the lungs and all of that, but additionally, they're not filtering their blood. So this is another lethal anomaly. Now, diverticula, we already talked about this a little bit, but it's the outpouching of that bladder wall. It can occur by itself, one diverticula, or it could be multiple diverticula. And it's caused by the mucosal herniation through defects in the muscle. So remember how I mentioned things like extra pressure on that muscle over long periods of time can kind of weaken and thin the muscle, or somebody that has some muscular defects can have that issue as well. So we're looking at people that have congenital or acquired diseases causing somehow some disruption of the muscle itself. One of the ways it's associated with a congenital abnormality that leads to diverticulus, it would be a bladder outlet obstruction. So you might have a totally normal bladder, but that bladder gets obstructed and now it's retaining too much fluid, and that increased pressure stretches that muscle so much that it's making it weaker and weaker, almost like a balloon that's blown up too big. And eventually, if that muscle gives way in an area, then it allows for the protrusion or the diverticula to occur. Other things like neurogenic conditions, again, these patients may not feel that their bladder is empty, or they may not be able to catheterize themselves as frequently as necessary, and that long-term distension of the bladder will weaken that muscle and then set it up for the possibility of that herniation of the muscular layer through the muscle. So, and then also intravesicular pressures, which would be caused by the two things and even other events that we talked about. Okay, one particular type of diverticula is called Hutch's diverticulum, or it's called or technically it's a paraurethral. So we're looking near the urethra here, and this one is due to a congenital abnormality where the ureter insertion is inherently weak where it connects to the bladder wall. And because of that, that muscle in that region near the urethra is going to be weakened and be more likely to herniate. General diverticula appearance, they look kind of like the images that, they really just, they're pretty basic. They look like the images that we've been seeing in this slideshow. So it would be an outpouching that communicates with the main bladder, and you have to show that communication to assure that you know that it really is coming from the bladder and not some ovarian cyst or something like that that could have a similar appearance. Now, some of the concerns about a diverticula is that it's really, when you urinate, it's not going to empty efficiently, and so it leads to stasis. And really, stasis is the root of most of the problems here with these diverticula. So because of that, we can see that stasis is going to cause the buildup of stones. It can cause infections, some more things that we'll go to momentarily. If it's not emptying, then it's going to fill up more and more and more over time. And as it fills up, it's going to be more at risk for bladder rupture, or in this particular case, it'd be bladder hernia rupture. Here you see that there is a bladder diverticulum. Here you see a disruption in the mucosal as well as muscular wall, and then you see free fluid external to the bladder. So this would indicate that there's probably been a bladder rupture. Now, sometimes if a diverticula gets large enough, it can be mistaken for the bladder itself. So that's why it's so important to make sure you tell a patient that they have to have a full bladder when they come in, because we want to not see just the diverticula. We want to see the diverticula and a bladder if it's full. If the patient empties and the bladder empties and the diverticula remains, we could be tricked into thinking that that diverticula is the bladder. It can also be, if we see a duplicated bladder, we can also be confused with that to see, because sometimes the two bladders will communicate with one another. So that's going to be a difficult differential diagnosis to see if is it a duplicated bladder or is it truly a diverticulum. We can also notice seminal vesicle or ovarian cysts that are associated with these diverticula, or we can even see the diverticula and assume that they're an ovarian cyst or a seminal vesicle cyst. We already talked about how spontaneous rupture of the diverticulum is possible, but rare. Without immediate diagnosis of this, it can look like acute renal failure and can be fatal. So you really have to watch that bladder wall and make sure that that it is continuous. The other way that you can determine if it is a bladder rupture is if you were to have a nurse start a urinary catheter and inject saline at the specific site, and if you could identify saline moving out of the bladder, or if the patient started with no free fluid and now they have free fluid after that, that would indicate extravasation outside of the bladder and that it was a bladder rupture and not something else. Here are just some images of a bladder, and you can see how tricky these diverticulum can be. So here's a bladder, two diverticulum. Here, looking at this, you might think, oh, those are ovarian cysts, or maybe they're dilated seminal vesicles. And so that's why it's important to come at multiple different angles until you can demonstrate these connections between the bladder and the two diverticuli. Okay. Just like there can be bladder diverticula, there can be urethral. So we're thinking about the urethra right now. So that external component, or the exiting component of the bladder. So if we had a urethral diverticula, again, it's going to be just another diverticula. It's just named by urethra, by where it's located at. Most of the time, if we're suspicious of a urethral diverticula, that would be an outpouching in the urethra, we might have to get some more higher resolution scanning in. So utilizing transperineal or transvaginal scanning in a female would be useful. Oftentimes we can actually see the urethra when you're doing your transvaginal scanning. So when you're doing your GYN studies and clinical, start trying to see if you can identify the urethra. Of course, it's going to look like a hypocochlear structure exiting from the base of the bladder. So just kind of see if you can start identifying that. So if you need to find it someday, you're ready. It's usually going to be hypoechoic or anechoic because it contains urine. Urine is a fluid, and those are typically anechoic. It will show striated muscles in the urethral wall, which will also help with the identification. So if we see the urethral diverticula, just like any other diverticula, they can appear very simple where they're just filled with urine, or they can appear more complex as the urine sits there, becomes static, and maybe produces debris and infection or other things. Over time, they can develop stones or cancer as well. We come back to this term anisotropic. So anisotropic is a simple term that basically says that when we use, there's certain organs in the body that when we use different windows, they're going to appear different echogenicities. So this is the urethra can be considered an anisotropic organ, just like the kidneys can be. So if you're seeing it at one grayscale and then you change windows or change orientations and it looks a little bit different, this is one you don't want to get overwhelmed with. Know that that can be normal for this. Now, posterior urethral valves is very sad because oftentimes it's not compatible with life, but as they have developed surgical interventions with these babies in utero, there's actually much improvement in viability. So posterior urethral valves typically affect males, will only affect males. And what happens with this is that a valve partially part of the way down the penis gets obstructed. And so the fetus in this case can't urinate. So what you'll end up seeing is what we call the keyhole appearance. So it looks like a very large bladder with a very dilated proximal urethra. And in this particular case, you would recognize that in utero. Now, up until 16, 17 weeks, when the baby's taking over the production of the amniotic fluid, you may not think that much of it, just that, especially if you didn't see this proximal ureter dilatation, you just think the baby had a big bladder. Now, over time, as the baby progresses and takes over that amniotic fluid responsibility, what you'll see is because they can't urinate, their amniotic fluid is getting lower and lower and lower. Therefore, they end up with oligo, which means low, or an, which means no, hydramnios. So oligo or anhydramnios, which would mean little or no fluid. Well, in utero, when we have little or no fluid, that means they can't do their breathing practice. And when they can't do their breathing practice, their lungs don't develop. So most of the time, if this is not addressed in utero, these little boy fetuses or little boy babies will pass due to pulmonary hypoplasia. Okay. Now, sometimes there can be milder versions of this where it's not completely obstructed, and obviously those children are going to fare better. Now, when we look at the term bladder outlet obstruction, we know the outlet of the bladder is the urethra. So usually if we have a bladder outlet obstruction, it's going to be somewhere in that urethra or the bladder neck that feeds into the urethra. So some of the things that can cause that obstruction would be agenesis of the urethra altogether. This would cause the bladder to not be able to empty. Congenital urethral strictures, the strictures, remember that those are going to narrow and make the outlet less open for flow. So this may not completely obstruct, but it's going to reduce the flow that's able to pass out through the bladder. Then we could have urethral tumors where this isn't so much congenital, but a tumor could grow in that urethra and obstruct. And then we have anterior urethral valves, similar to the posterior urethral valves, but not in the same location and not only affecting males. So any of these that completely obstruct the urethra, if they're congenital and they're found in utero, are really going to have those pulmonary hypoplasia effects on the fetus or the newborn. Anything that develops over time, such as the tumors, could have a healthy baby and then change into having these issues later in life. Okay. Now, even if you have a non-lethal outlet obstruction, it can cause things like thickening of the bladder wall because that stretching over time of the bladder is going to cause irritation and thickening of that wall. That stasis of the urine is going to lead to cystitis and inflammation, just like the thickening will contribute to. In males, anterior urethral obstruction is uncommon. It's usually the posterior urethral obstruction. And remember, that's because there's an occlusion part of the way down the penis. In females, the urethral obstruction is really rare too. And if you do find it, it is a soft sign or an indicator that the fetus or person may have some colacal or an intersex anomaly, which is really complex and unusual, but something that you're going to be covering in your obstetrics class. Exstrophy of the bladder is another thing that you should be able to identify when you're doing your obstetric scanning. So you guys are kind of jumping the gun with some of these, getting ready for your OB class. Now with this exstrophy, its X is outside, trophy is growth. So outside growth of the bladder, the term tells you exactly what it is. So it's an anterior defect in that urogenital sinus that was so important during embryology. It also has a defect in the skeletal system, and those two defects come together, and they allow the bladder to herniate through the abdominal wall defect. Lots of times it has a separation of the pubic symphysis, so that does not have a complete closure in the pelvis and allows the bladder to basically develop and grow outside of the abdomen and pelvis. So as you can see, this is an in utero picture. A little bit hard to tell where we're at, but this is a femur, this is the cord, and this is this large mass of material outside the anterior pelvis. And that's because that bladder is herniating through that musculoskeletal defect in the wall. Okay, another obstruction is going to be contracture of the bladder neck. So our bladder neck, if this is our fundus up here, here is our trigone, here is our apex, and then our bladder neck. Do you see how that muscular layer, that detrusor muscle, kind of protrudes and is a little bit larger right here near the apex at that bladder neck? Okay, so if you're having contracture or contractions of that bladder neck, it can make it more difficult for that bladder to urinate. If it's a consistent contraction here at that internal orifice, then it may prevent the bladder from eliminating at all. So over time, if the bladder is not eliminating and the kidney is pumping down urine, it's going to increase that intravesicular pressure, or the pressure within the abdomen. Bladder, that's going to stretch that bladder wall, making the muscular layer a little bit thinner and a little bit weaker. Over time, it can result in that vesicular diverticula that we talked about, or just a really large bladder capacity. If that urine is staying there for long periods of time, remember that puts you at higher risk for cystitis and infection and stones and all of those things that are associated with stasis. There's a syndrome of irritable bladder associated with enuresis or painful urination, and that can be because of spasms or contracture at that bladder neck. The bladder neck contracture is relatively rare and usually seen in females, and when it's seen in females, what's usually happening is that there's an obstruction of the bladder neck due to the periurethral muscle in the bladder, in the pelvic floor. Okay, ectopic ureters, we already talked about how usually those are associated with duplicating collecting system. Oh, excuse me, I'm sorry, that was duplicated ureters. Ectopic ureters are going to be ureters that are in the wrong place. So not going directly from the renal pelvis right into the corner of the trigone of the bladder. In both sexes, this occurs because the mesonephric duct migrates to a lower position in the urogenital sinus before it becomes a vas deferens. So remember that the mesonephric duct can also be referred to as the Wolffian duct. And in males, that is going to ultimately become the vas deferens. In females, it's really going to basically fibrose and go away. Well, when the mesonephric duct is migrating to its final position, especially in the male, the ureters can be carried with it. And as it pulls those ureters, it can pull them either too far or not far enough and cause the ureter to settle in an ectopic location. So in this particular case, that ureter then would not insert near the normal trigone area, but would insert somewhere else. If we look at where the ectopic ureters typically insert, in a female, it would be too low there in the bladder neck, distal to the trigone. It could go right into the urethra or the vestibule, the vagina, or the uterus. In males, it's usually going to insert into the seminal vesicle, vas deferens, or that ejaculatory duct, that is that connection between the seminal vesicles and the urethra that transverses through the prostate. Okay. Now, urethrocells are kind of tricky because if you look at this image, you see something, and I would almost, with just a quick glance, I'd be like, oh, this patient has an indwelling urinary catheter because it kind of looks similar. But a urethrocoel is quite a bit different. So a urethrocoel occurs right at the insertion of the ureter into the bladder. And because of some weakness in the wall right there, it will cause an enlargement of the lower end of that ureter. Now, sometimes that ureter can even kind of penetrate into that bladder and show a urethrocoel that looks like this. Okay. So problems here can arise because that urethral opening into the bladder wall becomes stenotic. So the pressure from this urethrocoel can kind of compress the UVJ, and then that would cause a backup of fluid or urine into the kidney. So it could result in hydroureter or a dilated ureter. Hydronephrosis, if it backs up far enough, it would dilate the pelvis or even out into the cortex of the kidney. Now, it also is going to be caused stasis, and so we know with stasis, then we can see associated with stasis infections, stones, and other things like that. Okay. Now, if it's large enough, it can not only compress that UVJ, which it's originated at, but if it gets large enough, it could almost even compress the apex of the trigone there where the urethra exits and cause a prolapse or pressure on that cystic urethral orifice. Now, an ectopic urethrocoel would be the same thing as a regular urethrocoel, except it's formed where there's an ectopic ureter. Here's an example of a little bit more subtle urethrocoel than the last. So you know that you're kind of looking for all different shapes and sizes. They're not always going to be that nice big balloon, but lots of times they are. So ectopic urethrocoels can change shape and size according to the intravesicular pressure. So if that bladder really fills up, it might compress the urethrocoel. If the bladder has just emptied, it may release that urethrocoel and allow it to get larger. In adults, they usually look like these round or oval, thin-walled cystic structures. Again, very similar to those indwelling catheters. But they can change, unlike a catheter, they can change shape as they fill and empty. They can also affect the flow of the urethral jets. And if we see a urethral jet coming right out of a urethrocoel, we know then that is a urethrocoel. It can also, if it's an ectopic ureter, the urethrocoel can actually help us identify where the ectopic ureter is implanting. With these, because they can affect flow, they can result in stasis, which would then cause stones. Excessive stretching from dilatation of the bladder can result in tumors and other things like that. Okay, urachal variants. We talked about this some, but we know how in the fetus the bladder communicates with the atlantoid canal into the umbilical cord. Now, the idea is that as that baby reaches maturity before it's born, that atlantoic canal should fibrose and become just a ligament. But in people that do not have a complete fibrosis of that urachal cord, they can have what we call a urachus. Now, it can't just be always a simple urachus. A simple urachus would be where the cord doesn't fibrose at all, and it leaves an open communication between the bladder and the umbilical cord, which after birth would then become the belly button. When it partially fibroses, then we get stuck with something called a urachal cyst. So a urachal cyst develops when both ends of the urachus close off, with urine trapped in the center of the urachus and left open. So in this particular case, you would find a cystic structure somewhere along the length of that urachal fibrosis. Okay. Now, with this, patients can sometimes present with a palpable mass, or like they can feel something because they technically really have a cyst filled with urine in their belly, but they can also have fever and dysuria. And some of that fever is coming because they have urine trapped in a sac, sitting there static for long periods of time that could cause infection. Then we have the urachal sinus, and this is in about 15% of cases. This is where the urachus closes at the bladder, but not at the umbilicus. So with this one, they shouldn't really have a lot of loss of urine out in, exiting their belly button, but you might see that there is that there is some abnormality along this urachal ligament. Then we can have a urachal diverticulum, and this is where the urachus closes at the umbilicus but remains open in the bladder. In this particular case, like right here, you would see no urine again is going to flow out. However, you're going to see an abnormally shaped bladder fundus because it's extending into that proximal urachus. So complications of a persistent urachal sinus include infection. Anytime we're having urine that's getting trapped in places or not having normal flow and exit, that's when you're at risk to get those infections, stones, and other things. So cystitis, which is just inflammation of the cystic bladder, is usually caused by urinary tract infections. And we know that females are at higher risk of urinary tract infections. So ultimately, they're probably going to be at higher risk of cystitis. Urinary tract infections are only secondary to prevalence in relation to respiratory infections. So they're very, very common. In younger people, they usually don't have that huge of an effect, but in our older population, they can really have a significant effect and make those patients very, very sick. So that's when it becomes responsible for significant morbidity and mortality. The origin of a UTI is usually caused by intestinal bacteria of E. coli 85% of the time, and that's usually from the introduction of fecal matter into the external orifice of the urethra. Therefore, more common in females because of the location of that urethral in relationship to the anus. The appearance of this would just be thickened bladder mucosal walls. Sometimes it can be universally thickened or diffusely thickened. Other times it might be thickness in more of one area. As that wall gets more and more inflamed and edematous, it can cause the development of cystic structures within the wall in those areas. Inflammation of the bladder always suggests a predisposing risk factor. So even if cystitis, that other 15% of the time that is not attributed to a urinary tract infection, it indicates that there's something else going on in the bladder itself. most of the time it would be that urethral obstruction. So could be something like the bladder neck contracture. It could be something like the posterior urethral valves. Anything that's going to prevent that your urine exit can cause stasis and can lead to infection. Catheterization can cause cystitis, obviously, because anytime we're introducing a foreign object into the body, we have the potential to introduce pathogens into there as well. The urinary system, unlike the vaginal system, is considered a sterile system. Bladder calculi is kind of interesting because bladder calculi can develop as a result of urethral obstruction, or bladder calculi could cause the urethral obstruction itself. So it's kind of a twofold risk there. Trauma to the bladder can also cause that inflammation. Pregnancy can make our body more inflammatory. It can also affect the ability to fully void, which would cause stasis and could lead to cystitis. Renal disease can also lead to cystitis, as well as radiation therapy. Both of those are going to inflame the bladder. Poor hygiene would increase the probability of introducing a urinary tract infection. Then there's common rectal or vaginal fistulas, where the rectum or the vagina actually communicates with either the bladder or the urethra. We know that those are not sterile areas, and so the introduction of materials from the vagina or the rectum could cause that inflammation and then the cystitis. Surgical instrumentation, very similar to catheterization, can introduce pathogens into the area. A bladder neoplasm, lots of times this could restrict the emptying process or the micturition process, lead to obstruction, and which could then ultimately lead to cystitis. Debilitating illness can reduce the effectiveness of voiding. Sexual intercourse can introduce additional pathogens to the area, which could then have a retrograde ascent up the urethra and cause an infection. And then obstruction conditions and then diabetes. We know that diabetes really alters our blood flow because it can cause stenotic areas in our vasculature, and it can make the body less able to address pathogens early. So those pathogens are going to be more likely to become more complex and lead to things like cystitis. Okay. If you want to look really specifically at the type of cystitis, it can be classified into bullous, where that's just an infection. And in this case of bullous infection, it would usually be focal bladder wall thickening in the early and acute stages, whereas if it goes on long term, the bladder may become small and contracted, kind of like those chronic disease processes of the liver and the spleen and the kidneys, where over time it's under so much assault, it kind of gives up fibrosis and shrinks. Candida albicans, that's a fungus. They can have, it could be hematogenous, meaning coming through the blood system. It could be delivered lymphatically through the lymph system, or from direct inoculation from the anus. So introduced directly from the anus typically into the urethra and then into the bladder. Now, most people have a really good immune system against fungus, so you're going to be at higher risk of Candida albicans cystitis if you have a compromised immune system, like our HIV, AIDS patients, chemotherapy patients, people like that. With this, you might see you're going to see that bladder wall thickening, more fluid debris interfaces, and things like that. If it's catheter induced, usually the catheter induced is irritation of that bladder mucosa. So it might just be that the catheter was introduced into the bladder and it hit the wall and irritated that wall. In other cases, it could have introduced infection, which would then lead to a bullous type cystitis. So if it was just from injury due to the catheter placement, usually you'll see a smooth, thickened hypoechoic area really early on. and then it can become more polyploid later in later stages, especially if you're having somebody that has to self-cath and they're continually injuring the same area. Cystic cystitis is going to be non-specific and inflammatory, so not one specific cause. It is associated with chronic cystitis or chronic catheterization, and when this occurs, you'll see a thickened mucosal area with cyst-like elevations, and sometimes even an intravesicular mass. So that's why it has those cyst-like elevations within the wall, which causes it to be referred to as cystic cystitis. Emphysematous cystitis. Remember, emphysematous really means containing air, and so this is usually caused by E. coli. That bladder wall gets infected. There's necrosis of different tissues or pathogens, and as those break down, they create air, and so you will get that typical dirty shadowing from gas, but it will be within the wall. An encrusted cystitis is usually when there's a buildup of urinary salts or precipitate on the bladder surface. In this particular case, there's focal bladder wall thickening sometimes in the early stages, and then over time, damage is done to the bladder more uniformly, and it will ultimately give up and become contracted in those chronic stages. Glandularis is usually caused by pelvic lipomatosis, so the development of little diffuse lipomas throughout the bladder, or chronic infection. And so this would have a diffuse mucosal thickening and echogenic fat surrounding the bladder. Then there's hemorrhagic cystitis, and that would be from the use of prolonged cyclophosphamide therapy, so a drug therapy, and with this hemorrhagic, you'll see echogenic debris caused by blood clots. So you're going to have that typical hemorrhage appearance as it bleeds and then goes through that clotting process, and ultimately, if the clot is not resolved, it will become focal calcifications. Okay, and then purulent cystitis, this is where we're producing pus. This is typically because of neurogenic dysfunction and urine stasis. So a bladder that's not emptying is going to have stasis. That stasis is going to lead to infection. Over time, that infection can get so significant that the white blood cells are dying off and they're creating this purulent material, and that would produce a pus urine fluid level. And then radiation induced, so maybe they're doing radiation therapy to treat some other sort of pelvic disease, pelvic cancer, or even bladder cancer. That radiation therapy can do damage to the tissues, causing cystitis. It can even cause ulcerations, bladder wall sloughing as those cells die and slough off, mucosal irregularities, and if it's too high, if too much damage is done, then they can create a fistula that might connect the bladder to the vagina or to the rectum or something like that. And then there's schistosomosis, and this is caused by that schistosoma hematobium, which, remember, is a parasite. And when that parasite is in the urinary tract, it can cause polyps or polyploid bladder wall thickening. It can cause wall calcifications with shadowing, fibrosis over time, and a contracted bladder in chronic stages. Now, those are a lot to think about and remember. So just do your best, try and connect the terminology with what you think it's going to do. The important thing is that you're able to identify the wall thickening, and then you can kind of narrow it down from there. So here's a patient on C that they're saying this is a blood clot. So this would be some sort of thrombus in the bladder. Maybe it's due to trauma, maybe it's due to some serious infection that ate through a vessel wall and caused it to bleed. And it's kind of in the moderate phases of clot formation. On D, you see a CT pelvis that shows right in here, this is the bladder filled with fluid, and then on the CT, the blackness would indicate air. So this would be an emphysematous cystitis. So this patient would have a really bad infection with a lot of necrosis in that bladder wall, causing the air to accumulate. Okay, calculi are, a little bit more obvious. We're used to looking at calculi in the kidneys and gallbladder in different places. Usually calculi are single and they can be asymptomatic. You could have a calculus in your bladder that was actually developed in the kidney, made it through the ureter and then into the bladder, or you could have a calculus that actually forms within the bladder. If that calculus that is within the bladder is able to get into the bladder neck and obstruct it, it can lead to bladder obstruction, which then would lead to all the things we were just talking about, caused by stasis of urine. So you could lead to cystitis, it could lead to the development or formation of more stones, other sort of infection, and things like that. The predisposing factors to stone formation include an increased concentration of salts in the urine. So as those kidneys are filtering out and resorbing different materials, if your salt intake or your kidney isn't working, or when we say salts, it can be not just sodium chloride like we think of salt, but it could be potassium, it could be other components that could be passed into the bladder. Urinary infection, urinary tract infection, often leads to stasis or is caused by stasis, or leads to the sloughing off of materials, and if those materials accumulate, they can create a stone. And we know that anytime that there's stasis and that urine sits, it's more likely to accumulate and create a stone. These will appear like any other stone. Echogenic foci, posterior shadowing, they may be mobile. We kind of want them to be mobile so that we know that they truly are a stone. If they're non-mobile, it's going to be a little bit harder to tell if they're a mass or a stone, but remember, even if they're not mobile, if they don't have any internal blood flow, then more than likely they're some stone. They don't have to be calcified, but most often we'll identify more easily if they are. We're going to use that patient movement and our color flow to make sure we're assessing through differential diagnosis whether it's a stone or a tumor. In a patient with diverticula, we know that those diverticula contribute to stasis, and so it's going to be more common to find infection and stone formations in that static area of the diverticulum. Okay, another common problem of the urinary system is reflux. So we talked about in our first week how reflux is really a significant concern because over time that reflux can really lead to some significant kidney damage. So it's our UVJ, or our uretrovesicular junction, right there where the ureter plugs into the bladder, that typically presents reflux. And we talked about how that bladder filling can kind of compress that junction and act like a valve. Now, if that junction is in an unusual place, then that compression is going to be less efficient and we're going to have more forward and backward flow through that junction. The UVJ typically protects the kidney from that static urine coming back at it. But if we have incompetent valves here, the risk of stasis and introduction of static urine back into the kidney increases, and that's then going to put that kidney more likely of infection, and chronic infection can lead to chronic damage. Reflux can be a result of ectopic inserts of the ureter into the ureter into the bladder. It could also be a cause of posterior urethral valves. So that posterior urethral valve causes an obstruction. That obstruction results in a ton of pressure in that bladder, and as that pressure increases, there's nowhere left to go, and it might go back up the ureters. Periureteric cysts could compress that ureter so much that it causes the reflux there. Prune belly syndrome, this is usually a result of somebody that has the prune belly results as usually from a patient that has posterior urethral valves, and so what will happen is that bladder gets so large in utero it causes the abdomen to expand dramatically, and so if if the fetus or newborn is able to survive despite its probable pulmonary hypoplasia, once they empty that bladder, it kind of deflates the abdomen and causes their little belly to kind of look like a raisin or a prune. So that prune belly is really associated with the posterior urethral valves and cause the reflux for the same reason. In the neurogenic bladder, again, these patients aren't able to empty their bladder, so that high intravesicular pressure can cause that reflux to go up the ureters. So vesicourethral reflux occurs in two distinct groups, one being neonatal reflux, which is more common in males. So when you start scanning OB, you'll see that it's actually pretty common for males to have a little tiny bit of hydronephrosis. If you see hydronephrosis in females, you're much more concerned. If we see reflux in older, even newborns to toddlers to young children all the way to adults, reflux at that stage is going to be more common in females. With reflux, depending on if it's occurring bilaterally, which would be most common if it was an obstructive issue, we can see bilateral hydronephrosis. If it's unilaterally, which might be caused by something more like a urethral or something just affecting a singular side, then we would typically see the hydronephrosis in a single kidney. It does have a high incidence of contralateral renal abnormalities, meaning just because the effect is on one side, it's oftentimes the contralateral side we see additional abnormalities as well. High pressure reflux, like those caused by obstructive disorders, with or without urinary tract infections, can be a cause of chronic renal failure. So that introduction of static old urine into the kidney over and over and over again can compress it and can cause major cortex damage, which would lead to chronic renal failure. And we can see that as atrophic, or like a shrinking of the kidney, and those types of changes. So we talked about the types of reflux and what causes them, but one of the reasons that sonography can prove to be a very valuable imaging modality for reflux is because, first of all, it's much less expensive than a lot of the other exams that would be available to diagnosis. There's also no ionizing radiation, and it can identify specific abnormalities. So some other options could be, a CT looking for bladder reflux, or even what we call a cystogram, where they inject radiographic contrast into the bladder and watch for it to reflux up. So both of those would require exposure to contrast as well as ionizing radiation, and probably come in more expensive than a sonography exam. So, so this is going to be your best low-cost option. However, it is definitely going to be user dependent, and so you have to really know what you're looking for to see that where we're not using contrast to identify that reflux when it does occur. It's also important that when we're doing our exams in the transverse plane, we have to meticulously scan over the area where the ureters enter the bladder. So even if you're not evaluating necessarily for reflux, get used to scanning down towards that trigone and actually looking for the urethral openings into the bladder. If there's going to be reflux occurring there, the ureter often dilates with urine as the reflux is in progress. So that may be one of the ways that you can diagnose that, along with the dilated ureter and other such events. Distal urethral obstruction, this would be at the UVJ, or the uretrovesicular junction. That obstruction occurs at the junction where it enters the bladder, right at the corners of those trigone. As I mentioned, avoiding cystourethrogram, which is done under live x-ray, can be required to differentiate UVJ obstruction from other non-obstructive causes such as reflux. And so with that particular exam, they start a catheter, They'll image the patient before injecting contrast into the bladder, and they'll fill the bladder full of contrast, and then they will actually remove the catheter and wait for the patient, which is oftentimes an infant, to evacuate or void. It's usually during that act of micturition that they'll see contrast, which will appear as a bright white, or what we would think of as echogenic, but we call it radiopaque in radiography. Um, we would see that bright white area moving from the bladder into the ureter, indicating that there was a retrograde reflux or retrograde movement. The cases of distal urethral obstruction can be congenital, or acquired. So things like the difference in placement of how the ureters plug into or join with the bladder can have a significant impact on how likely they are to have reflux in those areas. So now, if we see distal urethral obstruction, it can actually be caused by or appear as a couple different things. So one of the first thing is primary megaureter. So mega meaning very large, ureter. So this could be a congenital cause where that ureter is enlarged, and it therefore allows that reflux to occur more readily. There can also be primarily megaureter with coexisting reflux, primary megaureter with a coexisting bladder saccule, where that bladder would have some sort of outpouching, not so much a diverticulate, but a congenital outpouching. You could have a simple urethrosil. Remember, that was that protrusion of the ureter into the bladder, and also see reflux more commonly with the ectopic ureter, because again, with a normal UVJ, as the bladder expands, it compresses that UVJ area, shutting off the flow either forward or backward of urine. And if they have an ectopic ureter, as the bladder expands, it's not necessarily going to constrict that UVJ area, which could lead to some reflux. And then an ectopic urethrosil, which would go with an ectopic ureter with a urethrosil as well. Acquired causes would include urethral reimplantation procedures, where a patient has had their ureter removed from its natural implantation and readjusted or repositioned at a new location to the bladder. Infection is going to cause inflammation. It can cause all the structures to perform less efficiently, and that may result in some reflux. And then stricture following the passage of stones. So if a stone has passed and it has caused a lot of scar tissue in that ureter or the UVJ area, then that fibrous type tissue is not going to be as efficient at peristalsing and really staying compressible as it once was. And so because of that, you can have a hardened area, which then couldn't be compressed by the bladder, and therefore would allow reflux through of the urine. So sonographic findings, we can see megaureter, large ureter. Anything over 6 is considered enlarged. Megaureter is usually a term reserved for something that is very significantly dilated. Hydronephrosis, if that reflux is pretty significant and it's refluxing all the way up the ureter, then it can lead to hydronephrosis. And this is where kidney infections become more common, as well as with high-grade hydronephrosis. Remember, it compresses that cortex, and the cortex is where the nephrons are located. And by compressing those, it can kind of cut off its blood supply, do damage to the nephrons, and ultimately can lead to renal failure. And then another sonographic finding is really associated with the problem or what's causing the reflux, and that would be an ectopic ureter with or without a urethrosil. Now, neurogenic bladder is, if you think of it from the patient's standpoint, I think this would be kind of a devastating issue to have. So neurogenic bladder means you've lost control of your bladder. It could go either way, to where you can't voluntarily empty your bladder, or where you can't voluntarily control the emptying of your bladder. And it's due to disturbances in the neural pathways. Lots of times, like we talked about, this is going to be associated with the paraplegic patients and things like that. But sometimes you'll see a patient walking and talking and everything is fine, and yet they're going to experience this neurogenic bladder. Depending on the nerves, like I said, it can be overactive where the bladder is going to be spastic, or it's going to void without intent, or underactive bladder where they may not feel it, or they may not be able to void even when they need to. Lots of times like I said, this is common in people that have are paraplegic, but lots of people that are paraplegic are that way because they have a neural tube defect. So neural tube defect is very highly associated with the neurogenic bladder. And neurotube defects, you guys are going to find in OB class that you are really the front lines to finding these defects in your OB scanning. And these really should be picked up there to help that would help the patient and the parent prepare for what may be ahead, because it's going to be, it can, depending on the extent, be a very challenging abnormality to deal with. All right, so if we look more at neurogenic bladder, other causes that are going to affect the nervous system can theoretically affect the bladder. So diseases like neurologic diseases, including multiple sclerosis, and I'm going to take just a second to talk about this because lots of people suffer from multiple sclerosis really silently. You may look at a person, you have no idea they have this. What multiple sclerosis is, it's the hardening, just like sclerosis is the hardening, atherosclerosis is the hardening of your vessels. Multiple sclerosis is really the hardening of your nerves. And as they basically sclerose or harden, they function more and more poorly. And so because of that, there can be that nerve damage that leads to a neurogenic bladder. That should be cerenomelia. This is when basically it's a lower extremity defect where basically from the pelvis down, there is fusion of the legs, and so some people will call it looks like the mermaid disease, because babies born with this look like a mermaid because their lower half is fused as one. And then Parkinson's disease is a pretty common in elderly patients, but also can affect younger people as well. And so Parkinson's disease is a disease of the nervous system. You might associate it with hand trembling, difficulty swallowing, things like that. But another way that it affects patients is with the neurogenic bladder. And then congenital abnormalities. So partial or total absence of the sacrum or a meningeomyelocele. And a meningeomyelocele, let's break down this word. The meninges, that is the covering of your spinal cord. Myelo is the encapsulation of that, and then cele would be like an outpouch in your collection. So when we have spina bifida, we know that spina bifida is a defect in the posterior spinal processes of the spine. And when you have that, you can have it to a number of different extents. So if this is the back of the spine and there's a gap here, and that gap is very, very mild, then we might have just a little bit of a protrusion, or maybe not even a protrusion at all. If this protrusion is just of that outer covering, that is a meningeocele. Now, if the spinal cord that travels in that within those meninges also protrudes out, that would be a meningeomyelocele. So, and then if you have just the defect where nothing actually protrudes out, we call that spina bifida occulta. So with spina bifida occulta, you probably, this is associated with a little tuft of hair noted on a patient's sacrum. If you took an x-ray, you would see that they were probably lacking a spinous process of one of their lumbar spines, but really won't cause them a tremendous amount of abnormality typically. Now with a meningeocele, because it's just the meninges, it's just that outer covering of the spinal cord. If it's protruding, most of the time it's not going to cause that significant impact. They can have that surgically corrected, but hopefully no damage to the spinal cord was done. But when you have the most significant kind, the meningeomyelocele, that means your meninges and your
outer covering are both protruding out that spine, and damage is going to be done from to the spinal cord from that area all the way down. Now that is one of those that is really going to be a congenital anomaly that's going to result in neurogenic bladder. Okay, systematic diseases that can cause neurologic complications. We know that diabetes really causes a lot of complications because of how it disrupts our vascular system. And so if we're not feeding our neurons good blood flow, or we have damage to those vessels, which is preventing adequate blood flow to the neurons, then those neurons can be damaged or under functioning, and that can result in neurogenic bladder. Pernicious anemia would also affect the blood flow, and that is going to complicate things in the same way as diabetes. Infections such as herpes, polio, spinal cord abscesses, all of those could affect the neurologic areas. Trauma, such as a car accident, something else, traumatic injury that could disrupt that spinal cord. Obviously, that is going to cause neurogenic bladder. Brain and spinal neoplasms that could compress or alter the spinal cord. Central nervous system vascular disease. Again, don't get enough blood there, it can't function normally. And then heavy metal poisoning. Those heavy metals will build up in different places, and sometimes they can affect the neuron's ability to function. So overactive bladder, because of neurogenic bladder, have little to no control over their micturition process, but they also don't often empty completely. So while they may be, having incontinence and be very frustrated with that, the problem is that they're still retaining a lot of urine, and then they're at risk for stasis. When you're at risk of stasis, you're at risk for UTIs and stone production and that type of thing. Now, underactive bladders have the opposite characteristic. The patient cannot intentionally void, and that's always due to the neural system damage. And the bladder either doesn't recognize it as full, or it cannot stimulate the process of the neurogenic responses in order to accomplish voiding. So in this particular case, that excess pressure, if you're not self-catheting regularly, that excess pressure is going to result in stasis, is going to result in bladder distension. That could result in a diverticulum and all the things that go with that diverticulum. It could also put you at higher risk of bladder rupture or even reflux. So everything that you can imagine, by overfilling that balloon that we have called a bladder, you're going to weaken the wall, cause more probability of reflux, have stasis, cause higher probability of infection. If we get reflux, then we know that we're at higher risk of hydronephrosis, and then we're at higher risk for chronic kidney disease. So it's a number of different issues. Now, if you get on a good self-catheter regimen, then that you're at lower risk, but then remember, every time they're self-cathing, they're causing a little bit of damage to that urethra, and irritating the cells and possibly causing hypertrophy of the cells and ultimately masses and that type of fibrosis and that type of thing. Now, long-term neurogenic bladder can cause a trabeculated bladder and spasm of external sphincter. And so result of this is relative to the obstruction and narrowing of the urethra. Lots of times this could be possibly due to repeatedly self-cathing. Patients can find it difficult or impossible to void. The pressure in the bladder remains constantly high, and it can result in that detursor muscle, the muscle of the bladder, becoming very thickened and enlarged. And then that's when it can also develop saccules or diverticula, cause reflux, UTI, etc. Now, a trabeculated bladder, just means kind of irregular. So rather than having a very smooth bladder muscle wall, you might see a jaggedness of that bladder muscle wall as it kind of gives way. Some areas will be hypertrophic, some may give out completely and allow a diverticuli. So that's what we would refer to as a trabeculated bladder. This will cause chronically infected urine, because we're not getting adequate emptying, urine's becoming static, and so we're getting infected urine. Urine's more likely to reflux. That's going to lead to chronic reflux, and then if it's infected urine, then we're going to lead to pyelonephritis or inflammation of the kidney as well. Then you're at higher risk of leading to acute renal failure as well. Formation of stones because of the stasis, and then bladder debris, again, because of the stasis and the infection. Patients usually undergo serial excretory urography or voiding cyst or urethograms to evaluate for a neurogenic bladder. Sonography, we are not going to be able to see that live motion of contrast. However, we can look for those urethral dilatations that we talked about with general reflux. We can look and see if is that bladder trabeculated, does it have an irregular border or pretty smooth muscular area when it's expanded. We're also going to look to see if there's bladder calculi that would have formed because of stasis, or urethroectasis, where the ureter actually, ectasis means like a dilation or a relaxation of. So this would be where that ureter is not that 6 millimeters in size, a nice consistent solid tube, but you're going to see areas of dilatation and areas of narrowing, and that would be urethroectasis. And then hydronephrosis, like we mentioned. Okay, so here's an example. This is trabeculated bladder, and you see there's these little outpatchings or saccules here causing this irregular border appearance, and that could be from long-term neurogenic bladder. Post-void images show that they still remain, that they also have a smaller bladder, but it's incomplete emptying. And then here are longitudinal images where you see pretty significant pelvic ectasis. So we would say the pelvis is dilated and the calyces are dilated. So we could call this hydronephrosis with pelvic ectasis because we have pelvic and calyx involvement. So on something like this, you would definitely want to measure the cortex, make sure that that cortex is still 1 centimeter. Over time, if this persists, it's likely that that will regress the size of that cortex and move it into acute renal. Okay, so bladder wall abnormalities, one type is bladder wall thickening. Remember, the bladder should always be symmetric unless they've had surgery. So finding areas of bladder wall thickening is going to be very concerning. Now, sometimes that thickening could be because of a mass or a cancerous or a neoplastic region on the bladder wall. Other times it can be due to outlet obstruction, or it could be a result of self-cathing and continually hitting a particular wall with that catheter upon insertion. Other causes of irregular bladder wall or bladder wall thickening would be neurogenic bladder, where it has had to hypertrophy because of the large strain, because of the intercystic pressure, chronic cystitis or inflammation there, edema from adjacent inflammatory processes, radiation therapy to the other area, or like I mentioned already, the primary or secondary neoplasms. Patients with inflammatory bladder wall pathology can have signs and symptoms similar to patients with urinary bladder or kidney neoplasm. So some of the signs and symptoms you might see somebody that has kidney problems would be gross or microscopic hematuria. Somebody with a bladder problem may have that as well. They may also complain of flank pain or things like that. So if their patient is complaining of just kidney area issues, don't count out the bladder without looking at it. Certain other pathologies can manifest can cause bladder issues both extrinsically and intrinsically. So if we look at a case like endometriosis, if you're getting endometriosis, and let's say you have a large endometrioma, which you guys remember from GYN, that's going to be a mass of endometrial tissue that keeps bleeding and bleeding and bleeding into itself, and it can become very enlarged. When that happens, it can have mass effect on the bladder itself. And in addition, if there is any access, sometimes those endometrial cells can even implant themselves within the bladder, and then you would have that bleeding into the bladder from endometriosis. Regional enteritis, also known as Crohn's disease. This is Crohn's disease affects the small bowel, and it is basically a degenerative disease that creates big ulcers and sores in the bowel when it flares up. because of that and its close proximity, if one of those ulcerations can actually eat through the bowel and into the bladder. Neurofibromatosis, so if we look at the term here, neuro would mean, these would mean our neurons. Fibroma would mean little fibroid-like tumors. And ptosis we know means distributed throughout. So I know I showed you guys a picture last semester of somebody with neurofibromatosis, but it means this is a genetic disease where somebody that has this disease, anywhere that they have nervous tissue, will tend to develop and grow these lumps or these neurofibromas out of their body. And so they may be speckled, their whole entire body covered with neurofibromas. Well, because the bladder has neural tissue, neurofibromatosis can occur on the bladder as well, looking like masses. Now, these patients, it's not going to be a mystery. You're going to know they have neurofibromatosis, so it wouldn't be like you saw something unusual on the bladder and had no context. And then AV malformation, hopefully you guys remember this from last semester, but as our vascular system is set up, we know that we should have large arteries that feed smaller arteries, and those smaller arteries break through the arteriole, and the arterioles then go to a capillary. And through that, we take this large volume of blood and really narrow it down to passing just about one red blood cell at a time. And then the venule picks it up, takes it back to a small vein. That vein feeds it back to a larger vein and larger, and so on and so forth. So an AV malformation is when we go from large artery right into a large vein. And because of this, we never go through the adequate pressure changes that we should see here in the normal system. So what we see is this high pressure blood flow going into this low pressure system, and we get a lot of turbulence in this region. And because of that, it will cause venous dilatation. And if that's occurring in the bladder, it can actually almost look like a bladder mass. But if you put blood flow on it, it's going to show very turbulent blood flow, and you would know that it was venous in vascular in nature. Okay, now if we look at really the focal types of bladder wall thickening, we have to think neoplasm. So the transitional cell carcinoma, squamous cell carcinoma, and those are really just referring to the type of cell that the abnormal growth is originating from. So if it's a squamous cell that's covering in that mucosal area, then it would be squamous cell carcinoma. If it's a deeper cell that's transitioning to another cell line that started the lack to lose differentiation and cause this tumor, then we call that transitional cell carcinoma. They need a biopsy to diagnose these. So identifying the thickness and documenting that is going to be important, whereas you might not be able to tell the difference between the two. Adenocarcinoma, that would be from some of that epithelial or glandular tissue. Lymphoma is going to be coming from that lymphatic tissue or lymph. And then a non-neoplastic type would be a fistula. And remember, a fistula is any abnormal connection between two parts that should not connect. So lots of times in the bladder area, it would be a rectal, might be a rectal cystic fistula, so going directly from rectum to bladder. If it's a female, it might be cystic vaginal fistula going from bladder to that vagina. So those fistulas will be focal. On the diffuse side, you see that not only can those traditional transitional and squamous cell carcinomas be focal, but they can also then become diffuse. And so just because you have diffuse wall thickening does not mean it's benign. It could still very well be one of those neoplasms. Okay, now on a non-neoplastic note, if we look at another cause of bladder wall thickening, it would be from infectious and inflammatory responses. And we know that lots of things thicken when we have an inflammation, because we know that when we have an antigen reach an area of our body recognizes that antigen. It causes capillary dilatation. It brings extra white blood cells to attack the process, and it really will cause edema and thickening. So things like tuberculosis, schistosomiasis, and cystitis cystica, cystitis glandularis, and a fistula can all be infectious or inflammatory causes of focal wall thickening. So a lot of those same inflammatory or infective processes that we saw affecting other organs can also affect the bladder. Okay, and then when we look at diffuse, overall cystitis, where the inflammation is throughout the whole bladder, tuberculosis that becomes chronic usually then does affect the whole bladder, as well as schistosomiasis. I'm saying that wrong today, but I'll get it right next time. Okay, then there's other medical, they classify it as medical diseases. So just other abnormalities. They're not infection and inflammation, and they're not neoplastic. They would fall under medical diseases. So things like endometriosis, that can cause focal thickening if those endometrial cells get within the bladder wall. Amyloidosis, this is associated with exposure to asbestos, and if some of that got into the bladder wall somehow, that would cause focal thickening. Trauma could cause a hematoma. Both of those could be focal, and then a ruptured bladder would be focal thickening with obviously free fluid external to the bladder. If it's diffuse, medical disease would be cystitis, so that really falls under inflammatory too. Amyloidosis, again, that can become diffuse or all over the bladder. Neurogenic bladder is going to cause diffuse thickening because that whole bladder is going to be affected by those pressures, and you're going to get that detrusor muscle hypertrophy. Detrusor hyperflexia, meaning kind of like a spastic, overreactive detrusor muscle. And then bladder outlet syndrome, causing that dilatation throughout the bladder, causing that bladder wall to thicken because of the pressures, and then obstruction with muscular dystrophy. Now, if in the case of trauma, our biggest worry about the bladder is that it ruptures. So with severe blunt force trauma, such as pelvic crush injuries, oftentimes from being smashed by something or a car accident, this can be a concern. So it's typically the bladder will be, well, we know that the bladder is extraperitoneal. So if we had a ruptured bladder, that urine should be contained extraperitoneal. So we would more likely see it in the pericolic gutters, in the pouch of Douglas, in the posterior cul-de-sac, than we would be able to see it in, we might even see it a little bit in Morrison's pouch, but we certainly wouldn't see it within the peritoneum. Now, if there's just a small tear and just a little bit of urine leak, and the body is able to react and encapsulate that urine leak very quickly, then it would create almost just like a little cystic appearing structure. We would call that a urinoma, or a collection of urine outside of the bladder. Kind of like if you think about the biliary system when we talked about, we had a bioloma, and that was if there was a leak in the system and it encapsulated. It's the same sort of idea here. A urinoma, if it's brand new, it's going to appear anechoic and posterior enhancement. It can sometimes have irregular borders and contain septa. If it's large enough, it can compress surrounding tissue. If it sits there long enough, it may kind of eventually develop an infection. The best diagnostic procedure for visualizing the bladder rupture is cystography, meaning this is the one where they would start a catheter, inject contrast, and they'd immediately see if there was flow out of the bladder. Now, we could do something very similar where we could be scanning in live time. The catheter could be placed, they could inject saline into the bladder, and we could see if it flowed out. So it would just be at the doctor's discretion which one of those would be their choice. Okay, a hematoma, this is usually going to be caused by some sort of trauma, or something that would be oftentimes a result of some sort of surgical procedure. So a hematoma is going to look like a hematoma did everywhere else. So we're going to review it this one time, but I know that you guys have this down. So if it's an early hematoma, it's going to be anechoic. As that blood begins to develop a clot or fibrose, then it is going to become low-level echogenicity, and then it's going to become more and more and more advanced in its echogenicity as it goes on. Now, as it decides to resolve, it's going to become complex because some areas will start to necrose and become anechoic again, while other areas will persist and stay echogenic. And so we'll have this time period of a complex or mixed mass. Over time, if the whole thing is able to to necrose and break up, then it will just disappear and go back to an anechocaria. If it's unable to do that and it becomes a chronic clot, then it's going to stay echogenic for some time. Now, these can usually appear as an irregularity along the detrusor muscles or mucosal surface. Most of them are mobile and will move freely, but sometimes they can be kind of attached to a wall. Now, the thing here, if it's attached to a wall, you're going to be concerned that this could be a mass, it could be a hematoma. If you put blood flow on a mass, you're probably going to get blood flow because something needs to keep that tissue alive. But if you put blood flow onto a hematoma, other than maybe a feeder vessel causing the hematoma in the first place, you're really not going to see any blood flow there. So that's going to help you determine whether it would be thrombus or mass in this particular case. A bladder flap hematoma is a hematoma that's unique to a patient that's just had a recent C-section. So when they're doing a C-section, the surgeon incises or cuts through the vesico-uterine reflection of the peritoneum to get access to that lower uterine segment. So when you think about a C-section, I think, before I really studied this, I didn't really think that much about where they cut into the body. But if this is the bladder, this is the uterus, they really try to make their C-section incision right here at the lower uterine segment, just above that cervix before really the main body of the uterus. So in this particular case, hopefully they're operating on the patient with a catheter in, so that bladder should be empty, but they're still coming in very close proximity. If this is my bladder, they're still going to be in very close proximity to the bladder as they would excise in through the lower uterine segment here. Okay. Well, when they do that, they create a potential space between the bladder and the uterus. Now remember, these are both extraperitoneal organs, so this would be outside the peritoneum. And when they do that, that potential space is commonly known as a bladder flap, a space between the bladder and the uterus. So in this particular case, after the C-section, if that incision were to leak or if damage had been done, then blood would collect in that region and form what we call the bladder flap hematoma. With this, patients with the hematoma can often have a fever, feel a mass, and if they're bleeding profusely at a dangerous level, they can have a dropping hematocrit, meaning that they're losing their red blood counts or their red blood supply. To differentiate a superficial wound and a bladder flap hematoma, we have to be able to identify the rectus abdominis muscle. And remember, those are the two parallel muscles that run down really either side. If this is, sorry about my drawing, if this is the belly button, they run down either side of the belly button. They're going to help give you that six-pack. So if we see the rectus abdominis muscle posterior to the hematoma, we know that this would be a superficial thrombus. If we see the rectus abdominis muscle, a bladder, and then a uterus, and we see the thrombus down here, then we know that, and the patient had a recent cesarean section, then we know that that would be a bladder flap hematoma. Now, the problem with this hematoma is they can become infected, hence the fever we just talked about. It can the fever can be caused by the infected hematoma alone, or because of the surgery in general, they're at higher risk of infections. So things like endometritis, an abscess, a wound infection through the incision, a hematoma or a septic thrombophlebitis, so that would be throughout the body. There's inflammation of the venous system. A symptomatic patient that has a clinical history of leukocytosis, that would be elevated white blood count, that would suggest that there is an abscess. If there's a dropping hematocrit, that would suggest that there is a hematoma or an active bleed. The dropping hematocrit with the leukocytosis suggests that there is an infected hematoma or a bladder flap hematoma. Okay, on to bladder neoplasms. So, bladder tumors frequently found in patients with painless hematuria. They will have no idea that they have anything wrong. Sometimes that hematuria could be microscopic, as I mentioned before, or it could be gross, where they actually see, and I'm not saying gross as in, ew, it's gross, but just gross in that it's large enough we can visualize it. So it can be gross or microscopic hematoma. Other symptoms can include dysuria, which would be painful urination, urinary frequency or urgency. Usually the tumors are in the epithelial or uroepithelial origin, meaning that they're really in the superficial area, not so much in the muscle, not so much in the serosal region. Bladder tumors are one of the most common tumors of the genitourinary tract. Usually they can be identified if the bladder is filled and the wall thickness is greater than 3 to 5 millimeters, then whether it be diffuse, because we know some of these neoplasms can be diffuse, or focal, in any area, because remember, bladder should be symmetric. Any area over 3 to 5 millimeters has to be suspect for a bladder tumor. Because the bladder tumor is going to oftentimes obstruct some of the void of the bladder, meaning that it won't be able to fill as much, then it can also affect pressures in the bladder. It can also result in reflux and often cause hydronephrosis. Now, some of the things you might be tricked with would be that blood clot, and I talked about how you can differentiate the hematoma from a bladder tumor. Benign prostatic hypertrophy, you're going to see this all the time, where you see this big mass protruding at the base of the bladder. And remember how I said they often kind of appear heart-shaped. So if this is the bladder, you'll see this big protrusion that almost looks kind of like a heart right here. And you're going to want to ask, what is coming up on the base of that bladder? And what it really is it's really not involved with the bladder, but it's in the prostate, just inferior to the bladder, having mass effect on it. Cystitis, we know, can cause edema, so that would give us our thickened wall measurement. Fungal infections can adhere to the wall, causing it to look thickened. Stones can also adhere to the wall, causing them to look thickened. And then bladder trabecula, which remember is associated with neurogenic bladder, can also make the bladder wall look irregular and thickened. Tumors that are in the bladder, neck, or dome can be difficult to detect with sonography, but you have to make sure you're scanning all the way through, superior to inferior, all the way out of the bladder, so you're not going to miss anything. Cystoscopy, meaning that introduction of the camera up the urethra and into the bladder, that is going to be the gold standard. When they do that cystoscopy to look around, they can also take samples to do a biopsy right then and there. This is invasive and uncomfortable, requires anesthesia, and therefore is going to come with a higher cost. Okay, we can do endovaginal scans to look at tumors, because it gives us a little bit of a up-close image of the bladder, but that's obviously only in our female patients. We can also be helpful in staging tumors and determining the treatment effectiveness. Sonography is useful in correlation with cystoscopy, so maybe one or the other can't do the job in full, so combining the benefits of each of them can be the best combination. CT is technically the imaging modality of choice for identifying extension of bladder neoplasms, not so much for seeing the neoplasm itself, but to see if you've been diagnosed with a neoplasm, to see if it has metastasized or how deep into the bladder wall it's gone, then CT can be a really good option. Okay, now on to more benign neoplasms. So one of our benign neoplasms is the papilloma. And anytime you see the word, or the word part papilla or pap, you have to consider that is medical terminology for nipple-like. So with these are going to be a benign tumor. They're usually made of transitional cell carcinoma, but because they're usually made of similar cell type as the transitional cell carcinoma, but in this particular case, they're self-limiting. They're not going to grow out of control. And so the papilloma is considered benign. Now, if those cells continue to become more and more undifferentiated and begin to grow out of control, that's when it would transfer into that transitional cell carcinoma. Usually these are about half a centimeter to 2 centimeters in size, again, self-limiting. but they can appear similar to that transitional cell carcinoma because really they have a very similar makeup. And so without a biopsy, lots of times you're going to be suspicious of these, but not really know what they are until somebody actually looks at the cells. Okay, now with malignant neoplasms, there's over 70,000 new cases each year. 14,000 patients will die of bladder malignancies each year. This is the 4th most common type of cancer in men and the 8th most common type of cancer in women. So the populations that are going to have the greatest risk factors, almost 3 times the risk of other populations, are going to be men, white people, and smokers. When diagnosed and treated in localized stage before it is able to metastasize, bladder cancer is very treatable. A 5-year cancer-specific survival rate approaching 95% if it's treated in a localized stage. If it gets through one more cell line or gets through the bladder wall and into the neighboring organs, then that survival rate is going to drop very quickly. Okay, when we break down the malignant neoplasms, the 90% are going to be transitional cell carcinoma. Now remember, this is the malignant counterpart to the papilloma. So with this, the cancer begins as cells that normally make up the inner lining of the bladder. And anytime you add irritation to those cells, you're going to be at higher risk of triggering them to become undifferentiated. So things like smoking, analgesic abuse, which an analgesic is a fancy term for like the use of Tylenol, and exposure to industrial carcinogens. Think about the nicotine or the analgesics or whatever you've been exposed to sitting in that bladder, irritating the cells. That's what's going to really trigger them to become undifferentiated and lead to these cancers. Only 5% of these are squamous cell carcinomas, and yet that 5% is going to be the most aggressive type of carcinoma. These are associated with chronic inflammation, such as a neurogenic bladder, stones, and patients having bladder schistosomiasis. And because of those are incidents where the bladder is constantly under strain and stress. And because of that strain and stress, those squamous cells in this particular case are more likely to become undifferentiated and convert to malignancy. And then only 2% are adenocarcinomas, which is kind of interesting because when we look at the liver and we look at the kidney and we look at a lot of our other organs, the majority of malignancies are adenocarcinomas, but here they make up the smallest amount. Now, the adenocarcinomas, interestingly enough, are associated with urachal remnants and bladder exstrophy. So these would be associated mostly with congenital abnormalities. Okay, when we're looking at these malignant neoplasms sonographically, we can see especially the transitional cell carcinoma tumors, which again, those are going to be the most common. They usually look like an irregular echogenic mass. They can look like a polyp or polypoid or sessile, which would be more of a straight mass. They will typically project into the bladder lumen, which makes it easier to identify if they have a nice full bladder. They will always be fixed to the bladder wall because they have to be getting their blood supplies from somewhere. So when you rotate your patient, when you roll them to their side, these are not going to move. They may have acoustic shadowing, but it's not guaranteed. And the key is they're going to have detectable blood flow within the mass. Remember how easily these could be confused with a hematoma. It's going to be that blood flow that is going to let you differentiate the two. And then ultimately, if they're spreading and if they're not just protruding into the bladder, but they're also affecting the wall or maybe even trying to grow outside of the bladder, they can disrupt that normal uniformity of the bladder wall. So anytime you see a thickened area of bladder wall, you have to be suspicious of a malignancy. So here's some examples. Now on the left, we do see an irregular thickening of one side of the wall. And here you're going to say, well, I know my bladder always has to be symmetric, and here it's not. So you're going to be concerned right there. You're going to check your patient. You're going to roll them side to side and see if this moves. If it doesn't, you're going to document it, and then you're going to add your blood flow on. And if it shows blood flow within that mass, then you know that this is a very concerning instance. On the right, however, this is a transverse of the male pelvis. What you see is this nice big heart protruding into the bladder. And technically, it's not protruding into the bladder, it's having mass effect on the bladder. This is a patient that has a benign prostatic hypertrophy. And so this would be a benign process, which you'll see very commonly, not to be confused with the true bladder mass. Here's an example of more of a sessile type bladder area. It's an echogenic mass. It's protruding into the bladder lumen. Most likely it's not going to move with rolling the patient. They're going to put color on here, and if it demonstrates color, as you see in the right, the lower mass does demonstrate this color. That would be indicative of a true mass. Okay, now metastatic tumors from other places can also go into the bladder. So metastatic tumors most oftenly go to the bladder through direct extension, meaning it grows out of the organ it starts in and goes right into the bladder. So think about what's close to the bladder, and that kind of gives you your list for the most common metastasis to the bladder. So cervical cancer, uterine cancer, ovarian cancer, prostate cancer, and rectal cancer. They're all in that same location, and lots of time, once that cancer grows through its origin organ, it will go right into the neighboring organ. They can also have direct lymphatic or hematopoietic extension. So direct is the one I just described, but if it was a lymphatic, it would be lymphatic drainage from the organ that is affected, receives cancerous cells from that affected organ and basically drops them off in the bladder. That would be lymphatic spread. Hematopoietic spread would be the vascular system draining the affected organ, would pick up cells and deliver it right to the bladder, and that would be its path of spread. Prostatic cancer usually metastasizes to the seminal vesicles and the perivesicular connective tissue. So because of that very close location, it might affect all of those components at once, including the bladder. Stress incontinence is becoming more of a topic of study recently, but it's the most common micturition abnormality. We talked about it a bit in class. 40% of postmenopausal women are affected by it. It's caused by genuine stress incontinence, where this stress causes urination, detursor instability, where that muscle is maybe spasming or doing other things, voiding difficulty, fistulas, where it's draining uncontrollably, not going through the urethra, and then functional or congenital disorders. It can be temporary, where you might feel like you're a bit incontinent because you have a UTI, the muscles and things may not be working as well, or it can be permanent, where where it doesn't go. Stress incontinence is the leakage of urine from the bladder when you increase the stress in your abdominal cavity. So if you increase the pressure, it compresses that bladder and the urine comes right out. So things like the Valsalva maneuver, coughing, straining, Cassie was reminding us of jumping last week. All of those things could cause urination unintentionally. Physical therapy and urogynecology is now starting to focus more on this. They're doing different therapy approaches to try and provide detailed pelvic floor assessment, provide exercises and different things to help promote better control of the bladder area. So they can do endovaginal, endorectal, transperineal, and transabdominal methods, where we can all look, and it may be more common that we do so, to watch bladder filling and emptying. Obviously, these are going to be very sensitive exams for the patient, maybe not something you're going to be doing right off the bat, but as you're in your role as a sonographer longer, and as this particular area of interest kind of takes off and grows, this might be something that becomes more and more common. Okay, endovaginal ultrasound is sensitive and specific, but cannot be used exclusively Remember, we talked about a transperineal scan where basically you use your curvilinear, you cover it with a glove or probe cover, and then you simply place the transducer on the external genitalia of the female. And because of this, we can add additional information, especially when the transvaginal exam is contraindicated. Now, issues that would affect transperineal would be an overdistended bladder where we couldn't actually get the penetration to evaluate it completely, an excessively small field of view, bowel gas in the region, focal uterine contractions, bladder mistaken for cervix. I don't know, that's a bit of a stretch, I think. Hopefully you wouldn't do that. Fluid in the vaginal vault mistaken for a cervix, cervical cysts, and pericervical veins. So some of those could kind of throw you off on what you're looking at. I think you guys are better than that for most of these. So both endovaginal and the transperineal would be adequate approaches to assess that bladder. Okay, and the reason that usually patients are experiencing stress incontinence is caused by a poorly supported bladder neck. So sometimes as the pelvic muscles are stretched over time or maybe start to weaken, that can allow the bladder neck to be looser and not as well supported. Coughing or bearing down results on the bladder neck to move inferiorly, and when it does that urethra opens without intention and urine is pushed out. Surgical repair can be an option. Something called a suburethral sling and an anterior repair can be performed where they require placing a small piece of plastic around the bladder neck to hold it in place and at the same time lifting and stabilizing the sagging bladder. And with that, we have made it through our lower urinary system. So I hope you learned a lot. Who knew there was so much to the bladder? Try and convert all of this knowledge to common sense. Ask yourself, if I was a muscle under a lot of pressure, what would I do? Make a good reasoning for all of these abnormalities to occur. So thank you for joining me, and I hope you have a great week. Bye.